and how can we set up fully accredited training programs, it's a slow process. And whether you ultimately want a fully accredited training program in global surgery and then head towards dual accreditation, one in global surgery and one as a colorectal surgeon or pediatric surgeon, and whether people want to do what George has done, which is then spend the next 30 years 3 months in a low-income country and 9 months back in the UK, and have a sort of a job plan that looks like that. I don't know whether there's much appetite for that out there, but those are some thoughts.
Can I just say something, just on the same theme as Andy? Again, in Oxford, we're trying to incorporate global surgery into the medical curriculum and hopefully take that through to consultant level. So for any trainees who are interested, we've started with kind of undergraduate curriculum, and we have a special study module in global surgery, which has been very popular last year. And then we've got a global surgery core. So this isn't global health with surgery, it is global surgery, which is we're running in September. It's the first year. It's a week with 20 cap points, and the aim is that in the long term it will become a global surgery master's course. And then moving on from that, we're also trying to develop some global surgery fellowships for our trainees, which may be a whole year, it may be part of a year. And we've got some academic clinical fellows as well who do global surgery. And again, the whole idea is to try and embed global surgery within the kind of medical school and training curriculum, and we're kind of doing it at all levels, and hopefully it will, when you guys come to consultant level, it'll be a bit easier than it is for us. I'd love to have a career, a kind of a job plan like Prof. Azzy, where I can actually say to my trust that I'm going to go away for 3 months. But at the moment, most trusts are, it's just not possible. You just have to take your annual leave or study leave. But it would be ideal by the time you guys finish, if we could get to a stage we can start having that conversation with trusts, saying, actually, this is what Angus wants to do with his career, this is what Laura wants to do. But I think we're quite a way off that, and some advice from some, people like yourself, Prof. Azzy, as to how that's worked for you would be quite useful for us, I think. And I think, we just need to consider all sorts of models that is beneficial for both parties.
Well, the first thing to do is to be Canadian.
Yes, right. I'll work on that.
It's always been an ethos, if you will, in Canada. There are very few medical students who've gone through Canadian programs who don't know of Norman Bethune or Lucille Teasdale, or there's actually a surgical history to the global mindedness, if you will. Thankfully different from our brothers and sisters below the 49th parallel. The other thing is that it's a right place, right time. I assume the same thing's happening in the UK that's happening in North America. Is there's a tsunami of interest in global surgery and in global health on the whole. So that if, as Nivi hinted or mentioned, I have an adjunct professorship at the University of Pennsylvania, it's not on the basis of intelligence, good looks, or charm, none of which that I have, but it's because they want to be able to send trainees for global surgery experiences overseas. And I've managed to leverage that into changing a program where they were looking to send people to practice on what I thought was a vulnerable population to do, because American program directors were saying our trainees are no longer learning open surgery in the continental United States. We need to send them overseas for that. And we've morphed that program into an elective program at the University of Pennsylvania, where they come solely to address ACGME competency of systems-based practice. So that the trainees who come have a research project before they ever come, they have designated readings that they have to do, and they don't operate on a single patient. They'll come to clinics, they'll learn, they'll come in and understand the context, they have to have a scholarly project that they leave behind, but that's essentially it. And UPenn likes the idea of having set itself apart and looking even better than Harvard in that light. So it's about playing a bit of the game. Like, if you can figure out a way. And the other thing, too, is I've had to be scholarly about this. The fact that Nivi would think of inviting me for something like this, the University of Toronto likes that idea of saying that we're now, rubbing shoulders with the likes of Prof. Laku and Andy Leather. Justify your existence. If you can publish, if you can present, if you can try to establish programs, establish partnerships, show some value added. I think, you want to be thoughtful from the heart. I think it's got to start there, but then you want to be thoughtful from the head as well. Be a little Machiavellian about what you do. And, Nivi started by asking, why Botswana? I mean, I had been in Sierra Leone, I had been in South Africa, I've traveled to other African countries. Botswana is a manageable mouthful. It's the size of France, but it's less than 2 million people. There had never been a pediatric surgical program, so I was not going to have to tear something apart and try and rebuild it. It's a democracy. It's a stable government. It's a lot easier living there at my age than it was living in Sierra Leone. So there are a lot of factors that come into play that people don't talk about that I think are important to discuss, and that the likes of King's and Oxford and others can give the mentorship that's required so the next generation is even more successful than we've been.
Would I be able to ask a question, please, Prof. Azzy? It's Naomi here from King's. I was just wondering about you were mentioning how the medical students and junior doctors have this fellowship where they do research in Botswana, is that right?
They have a research project, or I use the term scholarly project because research has a bit of a negative connotation even in Botswana, where the partners have basically owned the projects and locals have not been part of it.
That was going to be my question. How much training do you provide in terms of research for the locals so that they can be equal partners on the research project and equally participate in the research and therefore in the authorship list?
Yeah, so we've tried to be as thoughtful as we can of the authorship list, so it might be worth looking at what we've managed to publish over the past years and see if I'm lying or not. But of late, the locals have been the first authors on everything. And that's the interesting thing with the University of Botswana is that because there was never a medical school, the criteria for a post as lecturer, senior lecturer, assistant professor, associate professor are very clearly linked to publications. And so somebody like Alamayo Ginbabadada, he and I interact on an almost weekly basis to talk about where he is with regard to his scholarly project. With regard to the PGY4s who come from UPenn with me, so one came earlier this year in March for a month, Elijah Riddle. A woman will be coming, Grace Lee now, and they all have about a reading list of about 10 to 12 articles. We try and establish a new clinical pathway every time one comes. So we've probably got about 15 clinical pathways that have been established for common problems for the interns and medical officers at Princess Marina and Nyangabwe Hospital. And then we encourage them to try and help upskill locals in whatever way, shape, or form they can. It may be with regard to curriculum development. It may be with regard to a publication. It may be just reviewing the papers and the syntax for people for whom English is not their native language.
Brilliant, thank you. That really sounds great. I'll just add something about what you were speaking about, the sort of registrar training in global surgery. I know we haven't quite got that in the UK yet, and it's something that a few people have said they would like, and certainly Andy's been talking to the presidents about whether it's a possibility. I have been speaking to a few people around the world where it does happen. So in Amsterdam, they do have a formal global surgery training program. I believe it's a 4-year program, and they train appropriate skills. So they will train someone in all the different surgical specialties, including obstetrics and gynecology, and you're very much a generalist fit for working in, for instance, sub-Saharan Africa. If you then want to work in your own country, so if you want to work back in Amsterdam or in Netherlands, then you have to do the local training there as well, the full surgical training again. So a lot of surgeons will do global surgery training, work in Africa or another low and middle income country region for a while, and then come home and do the full surgical training again in their own country. So they're not really allowed to practice as a surgeon in their own country based on that training, which is interesting, something to consider whether that's what we want, or whether we want a surgical training program where we're trained to be surgeons in our own country as well as being appropriately skilled to work in low and middle income countries.
Yeah.
And then in Texas, I think linked to the Baylor University, they have a global surgery training program that's similar to the one that's run in the Netherlands. So just there's people around that are doing it, and we can learn from them, I think.
I think so. I think if you look at, you have to decide what paradigm is right for you. Like it or not, because in terms of medical specialties, a surgeon's credibility still comes from her ability to look after a patient and to operate. And if you look at the leaders you've got here, you've got Andy and Prof. Laku, they were first and foremost surgeons before they became the global surgery or global health specialists that they are. So I do think that there's something to be said for getting the credibility first and foremost at a clinical level in your home country before you go and poke your nose in other places. But then again, it may be a paradigm that needs to evolve. With regard to the impact that you're going to have, I mean, you yourself, so you're collaborating with Gabby Hyman, aren't you?
Me, yeah. Well,
Yeah.
Gabby is she's the country lead for South Africa, and she's involved in lots of different projects I'm doing, yes.
But what I want to say is, I mean, I already knew, we've never met, but I knew about you before ever seeing you on screen, right? So I think you're already having a significant impact in terms of when she and I are sitting together having lekker cake and coffee in South Africa, we're talking about you and the positive impact you're having on her. So, well done.
Oh, thank you. I guess that's just something I was just about to reflect on, actually, is the two global surgery programs I know that are running are very much clinical global surgery programs. So they train someone how to do surgery in a low and middle income context. Whereas I guess at King's and Oxford and other places, it's very much an academic global surgery training. We're not being trained clinically to do operations from all different specialties. We're being trained how to do research and training and other things appropriately in that context.
Yeah.
Maybe that we should have a combination. Who knows?
I think we're just about out of time from our side. I think people are quite keen to get some dinner, or I'm sure Prof. Azzy's lunch break is now very close to finishing. But I just want to say thank you so much to everybody who joined in and collaborated. Prof. Azzy, we really, really appreciated having you here, and your input was incredibly valuable to us. Likewise to Andy Leather, Prof. Laku. Thank you to everybody that contributed, and look forward to doing this again sometime.
Maybe
Thank
I
you
would
very
like to
much.
congratulate you on this fantastic coordination of this program. I mean, it's run like clockwork. So
Thank you. Thanks.
And to the native Brits, good luck at the World Cup.
We're getting there.
bye.
Bye, everyone. Thanks again.
Bye.
Thank you, Nivi.
No worries.
Nice meeting you.
Thanks, Nivi.
Bye.
This side of you, Neve. Just a little mouse in the department and just look at it.